And we are live now. With all your permission, I'm starting this session. Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with none other than Dr. Veena Shinde ma'am. And let me share some of the achievement of ma'am. Ma'am had done MMBS, MD, OPSI and Gynae, DGO, PG in Assistant Reproductive Technology, consultant at Shinde's Medicare Hospital, and Spadan IVF, Mumbai. And today, ma'am is going to speak on a topic impact of preeclampsia on future health on the evening of World Preeclampsia Day. By taking no more time, with all your permission, I am inviting ma'am. Hand over the session to ma'am. Over to you, ma'am. Kindly proceed from here.
Preeclampsia. Preeclampsia has an impact on the brain, cardiovascular system, pulmonary system, liver, hematological dysfunction, hypertension, fetal growth restriction, and death, and the kidneys. So, preeclampsia is not a simple subject. Slide. Globally, about 4 million women are diagnosed yearly, resulting in over 70,000 maternal and 5 lakh neonatal deaths annually. Survivors face increased risk of stroke, cardiovascular disease, and diabetes. Patients from preeclamptic pregnancies are at a risk of preterm birth, perinatal death, and long term health issues like neurodevelopmental delay and metabolic disease. Preeclampsia is a complex multi-system disease occurring after 20 weeks of gestation. The diagnosis includes sudden onset hypertension and at least one associated complication like proteinuria or organ dysfunction. It's a leading cause of maternal and perinatal morbidity and mortality. Preeclampsia affects the fetus and multiple maternal tissues. If you see the brain, it can cause eclampsia, hemorrhagic stroke, seizures, visual disturbances, cortical blindness, arterial ischemic stroke, cerebral venous sinus thrombosis, and severe headache. In the vasculature, there is reduced blood flow, for example, to the heart and the kidney, systemic endothelial dysfunction, coagulopathy, and thrombocytopenia. In the lung, it causes pulmonary edema. In the liver, it causes HELLP syndrome and severe liver dysfunction. In the kidney, there is endothelial injury, glomerular endotheliosis, proteinuria, and renal failure. In the placenta and the syncytial stress is seen. Angiogenic imbalance is seen. Placental abruption is seen. In the decidua, there is inadequate spiral artery remodeling. And in the fetus, there is fetal distress and growth restriction. Obstetric history, primiparity increases the likelihood of preeclampsia by threefold. Preeclampsia may arise due to immune maladaptation and maternal alloimmune reaction to paternal antigens on the fetal allograft. This reaction is strongest during the first pregnancy, hence primiparous mothers are more susceptible to preeclampsia. Multiparity is a protective against preeclampsia, but this protection diminishes with exposure to new paternally inherited antigens in subsequent pregnancies. Obstetric history. Increasing inter-pregnancy interval, that is more than 10 years, carries a risk of preeclampsia similar to that of primiparity. Women conceiving through IVF or intrauterine insemination with donor gametes face a higher risk of preeclampsia compared to those using autologous egg or partner sperm. Mechanisms, pathophysiology. The establishment of a healthy pregnancy requires good placentation. Healthy placental function relies on extensive villus branching and vascularization in early pregnancy, mostly formed by the end of the first trimester. Pregnancy begins with blastocyst implantation into a receptive endometrium during the mid-luteal phase of the menstrual cycle. The mechanisms and the pathophysiology. The placenta develops from extraembryonic lineages in the blastocyst. Trophectoderm cells differentiate into villus progenitor trophoblast forming syncytial trophoblast or invasive extravenous trophoblast. While extraembryonic mesoderm forms villus core, stromal tissue and blood vessels. The placental villus comprises two trophoblast layers, syncytial trophoblast in direct contact with maternal blood and cytotrophoblast anchoring the placental villus to the maternal decidua cells via cell columns. Extravillus trophoblasts invade the upper third of the myometrium from around 14 days after implantation until 18 weeks of gestation, largely completing placentation. Systemic consequences of preeclampsia onset. Vascular involvement. Maternal endothelium is a key target of placental release factors implicated in preeclampsia. Widespread endothelial dysfunction contributes to systemic organ damage in preeclampsia. The endothelium regulates smooth muscle tone and production, release of vasoconstrictor and vasodilatory factors, including nitric oxide, and controls anticoagulation, antiplatelet, and fibrinolysis functions. Systemic consequences of preeclampsia onset endothelial dysfunction results in reduced blood flow to the organs like heart and kidneys, along with diminished venous blood drainage associated with venous congestion. This dysfunction leads to organ dysfunction and reflex constriction of arteries, contributing to hypertension in preeclampsia. Pulmonary edema, characterized by excessive fluid in the lungs, it occurs in 0.6 to 5% of women with severe preeclampsia. It's the second most common cause of death in pregnancies complicated by hypertension. Causes include decreased oncotic pressure, increased capillary permeability, increased hydrostatic pressure, and diastolic dysfunction. Pulmonary edema risk factors include antihypertensive medications and excessive fluid administration. Postpartum pulmonary edema is most common as fluid sequestered in the extravascular spaces moves into the vascular space, increasing central venous and pulmonary capillary wedge pressure. Renal involvement. The kidney is the primary organ affected by endothelial injury in preeclampsia. Renal biopsies of preeclamptic women show glomeruloendotheliosis characterized by endothelial cell swelling, fenestration, obliteration, and capillary space invasion, leading to decreased glomerular filtration rate. Renal involvement, high concentrations of SFLT1 in preeclampsia inhibit expression of podocyte-slit diaphragm proteins like synaptodin and nephrin, causing proteinuria by increasing the interpodocyte separation. Reduced vascular endothelial growth factor and placental growth factor availability in the glomerular endothelium stimulates endothelin 1 expression, promoting podocyte detachment. Liver involvement. Liver involvement in preeclampsia presents as periportal inflammation, hepatocellular damage, and elevated transaminases, often accompanied by right upper quadrant or epigastric pain. Rare complications include subcapsular hematoma, hepatic failure, or rupture. Widespread microangiopathy induces vasospasm of hepatic sinusoids, promoting fibrin deposition and ischemia. Liver involvement. Hepatic endothelial cells reliant on vascular endothelial growth factor are affected by SFLT1 antagonism, reducing nitric oxide availability and altering function. Ischemic leads to oxidative stress and inflammation in hepatic acini, elevating liver enzyme concentrations in blood and contributing to the onset of HELP syndrome. Neurological involvement. Neurological symptoms have long been recognized as high risk factors of eclampsia. Neurological complications are a leading cause of maternal deaths in preeclampsia, especially in middle income groups. Complications include eclampsia, that is seizures, visual disturbances, stroke, cerebral venous thrombosis, and various forms of hemorrhage and syndromes. Neurological involvement. Some complications like cerebral venous sinus thrombosis, reversal cerebral vasoconstriction syndrome, and posterior reversible encephalopathy syndrome are more common postpartum and may occur with little warning. Neurovascular dysfunction in preeclampsia involves increased sympathetic activity, impaired cerebral autoregulation, blood-brain barrier permeability, and vasogenic edema. Dysregulation of cerebral markers like neurofilament light chain is observed in preeclamptic cerebrospinal fluid and serum plasma. Fetal growth restriction. Fetal growth restriction is mainly due to placental dysfunction and is highly associated with preterm preeclampsia. Inadequate trophoblast invasion during early pregnancy leads to poor uterine spiral artery remodeling, resulting in hypoxia and nutritional deficiency, contributing to fetal growth restriction. Late onset preeclampsia with fetal growth restriction is often associated with low placental weight and more vascular and villus abnormalities than late onset preeclampsia alone. Fetal growth restriction. ISSHP recommends assessing fetal growth velocity, amniotic fluid volume, and umbilical artery Doppler every 2 weeks in pregnancy with suspected fetal growth restriction. Through the utility of umbilical artery, Doppler close to term may be limited. In low resource settings, monitoring fetal heart rate, cardiotocography every 6 hours, maternal characteristics proteinuria can be used to estimate perinatal risk at more than 32 weeks of gestational, as gestational age primary drives risk before this point. Effect on women with a preeclamptic pregnancy. It is well established that preeclampsia is a risk factor for long-term adverse cardiovascular, renal, and cerebrovascular events. Consequently, women with a history of early onset and late onset preeclampsia have a 5-fold and 1.65-fold increased risk from cardiovascular disease-related death, respectively, compared with women without a previous history of preeclampsia. Associations of pregnancy conditions with cardiovascular disease death. Model number 1, univariate and variable, the hazard ratio. Ever had a preeclamptic pregnancy with a 95% confidence interval? Ever had an IUGR child? Ever had pre-existing hypertension? Age at enrollment, years, BMI at enrollment, current smoking at enrollment, ever had a pre-eclamptic pregnancy, ever had an IUGR child, ever had a pre-existing hypertension, age at enrollment, and the BMI at enrollment, and current smoking at enrollment. So all these factors, that is the age, whether there is a history of eclampsia, whether there is a history of existing hypertension, what was the age at enrollment, are very important factors. Smoking is also a very important factor. Cardiovascular disease death hazard ratios by gestational timing. Risk group preeclampsia less than 34 weeks of gestation. The hazard ratio is 9.54 and the deaths that were observed was 7 and the number of person in years was 1531. Preeclampsia more than 34 weeks gestation and 17 deaths were seen in 11,999 patients. No preeclampsia, 242 deaths were seen in 3,94,596 patients. Preeclampsia and renal disease. Observational studies have also recorded 5 to 12-fold increased risk of having end-stage renal disease for women with a previous history of preeclampsia in 2,99,300 women. Within preeclampsia groups, women who had early onset preeclampsia have a higher burden of kidney disease than women with late onset preeclampsia. Preeclampsia neurological complications. Cerebral blood flow autoregulation. The brain requires relatively constant cerebral blood flow across a wide range of perfusion pressures due to its high metabolic needs. Insufficient blood flow can lead to ischemic brain injury, as in ischemic stroke or hypovolemia from hemorrhage. Conversely, decreased cerebral blood flow can cause hyperperfusion, leading to blood brain barrier disruption and vasogenic edema, as observed in some cases of preeclampsia or eclampsia. Posterior reversible encephalopathy syndrome. Eclampsia, characterized by new onset seizures in women with preeclampsia, often presents with preceding neurological symptoms like headache, visual changes, nausea, mental status changes. Early angiographic studies propose cerebral artery vasospasm in response to acute hypertension, causing regional hypoperfusion, ischemic damage, and cytotoxic edema formation. Posterior reversible encephalopathy syndrome, the rapid resolution of symptoms and radiological findings postpartum suggests the absence of true cerebral ischemia in most eclamptic patients. Alternatively, hyperperfusion due to autoregulatory breakthrough resulting vasogenic edema has also been suggested as a potential etiology. White matter lesions, preeclampsia and eclampsia, historically viewed as gestational conditions, may have long term effects on the brain. Long term studies show significantly higher rates of white matter lesions on MRI in women with a history of preeclampsia or eclampsia compared to those with normotensive pregnancies. White matter lesions appear as hypertense regions within the hemispheric white matter on T2 weighted MRI images. These lesions are believed to result from small vessel disease within the brain, suggesting long lasting neurological implications of preeclampsia and eclampsia. Cognitive changes. Some women with a history of preeclampsia and eclampsia report cognitive, emotional, and mood changes in years following. Common complaints include impaired concentration, memory, and ability to attend to tasks. Studies using patient self reports indicate that women with prior preeclamptic or eclamptic pregnancies perceive more cognitive difficulties and worsen quality of life compared to controls. Stroke. Stroke in young populations is rare but carries high long term morbidity and mortality, significantly impacting families. The incidence of stroke in non pregnant females aged 15 to 44 is approximately 9 per 1 lakh, increasing to 10 to 34 per 1 lakh deliveries during pregnancy. Preeclampsia in pregnancy raises the risk of stroke by 4 to 5 times compared to normotensive pregnancies. Between 1997 to 2008 in the United Kingdom, 18% of preeclampsia or eclampsia related deaths were directly attributable to stroke. Clinically, patients with stroke in the setting of preeclampsia and eclampsia commonly present with headache up to 96% and are often hypertensive with a systolic blood pressure typically 150 to 160. Effect on the child of a preeclamptic pregnancy. The long term effect of preeclampsia on the child's health is mainly caused by fetal growth retardation and medically indicated preterm birth. Therefore, these effects are most often associated with preterm preeclampsia. Effect on the child of a preeclamptic pregnancy. It has been shown that children with fetal exposure to early onset preeclampsia are more susceptible to cardiovascular dysfunction, that is 310, and hypertension. In addition, children born from severe early onset preeclamptic patients are at a higher risk of impaired cognitive ability and neurodevelopmental outcome. Psychosocial effects. Preeclampsia has severe negative effects on psychosocial profile of the woman. Such effects are associated with severity of preeclampsia, timing of diagnosis, and pregnancy outcomes. Independent observational studies report that a diagnosis of severe preeclampsia has a worse impact on mental health and quality of life than diagnosis of mild preeclampsia. Future directions. Single cell sequencing is an exciting opportunity to understand the heterogeneity of cell responses during placental development. However, presently it is difficult to determine how placental single cell RNA sequencing data can be interpreted with respect to the syncytium, and it is a multi-nucleated single cell that covers the whole of the placenta. Combining single cell sequencing with spatial transcriptions or proteomics may better define the molecular interactions during placental development. Can we have the questions?
Yes, ma'am. Thank you so much, ma'am, for taking out your precious time and sharing your knowledge on this topic, ma'am. Ma'am, I definitely think this session knowledge is going to help all the participants on their practice also. We have received some question, ma'am. If you allow, with all your permission, shall we take these questions, ma'am?
Yes, we can.
The first question is from Dr. Anjana, and she is asking, what is the recommended follow-up care for women with history of preeclampsia to monitor the for future health risk?
See, preeclampsia lasts for at least 14 days post delivery. The first thing that happens post delivery is the blood pressure comes down but there are risk of spurts of blood pressure rising after 14 days. So for the first 14 days, the patient should be monitored and should be given rest, and till all her organs come back to normal, the patient should not be allowed to exit the hospital. Also, there should be salt restriction in the diet, uh, good monitoring of the blood pressure, urine output, and we should see that the knee jerk is normal.
Thank you so much, ma'am, for sharing your insight on this question, ma'am. We have another question from Dr. Gopal Srivastava, and he is asking, what are the long-term cardiovascular risks associated with the history of pre-eclampsia patients?
The long term cardiovascular risk are higher chances of hypertension and cardiac failure. That is why the BP must be monitored even post delivery. And salt restricted diet should be given, and the patient should be explained that during the next pregnancy also she can go through this. So she should get antenatally registered soon. If the age is less or if the age is more, the risk increases. If
Okay,
there
ma'am.
is a
Thank you so
maternal
much.
history of preeclampsia, then there is more chances that it happens in the daughter of a preeclamptic woman.
Okay, ma'am. I hope that doctor have received his answer. Moving forward, I can see one last question, ma'am. We'll be taking what are the current guidelines for the management of mild versus severe preeclampsia, ma'am?
See, in mild preeclampsia, we generally start with magnesium sulfate. So, magnesium sulfate is a very good molecule because it prevents the progress from preeclampsia to eclampsia. Also, a good antihypertensive should be given. All blood tests for HELP syndrome and for renal function tests, and a good monitoring of the BP and keeping the patient in a dark room helps to prevent the preeclampsia from going into eclampsia. Also, a good urine albumin test should be done regularly. Generally, what happens is the patient is normotensive and suddenly the patient becomes hypertensive and they have IUFD. Such patients always give history of IUFD in the past. So when somebody gives a history of IUFD, we must be more careful and do the urine albumin. I have had such patients who had come to me with history of two IUFDs in the past. Now, right from the beginning, as soon as 20 weeks started, we started monitoring the BP every day, and also we did a urine albumin test. As soon as the and we already started them on antihypertensives, generally labetalol or Nicardia retard is given to such patients. When we give these two molecules, the chances of BP going high is very low. If the patient is already hypertensive, we must switch them to these two molecules because they don't affect the blood brain barrier, and therefore they don't go from the placenta to the fetus, and because of that the child's growth is not restricted. I had one patient from Kashmir who used to take atenolol in her prior to her pregnancy, and she had continued it during the pregnancy, and she landed up with fetal deaths. So when she came for the third time to me, I understood her problem, and then I put her on labetalol and Nicardia retard from the beginning. After she delivered a live child, and after that she was happy because she understood the cause of the fetal death. Remember, all medicines do not are not supposed to be given during pregnancy. So always check with the obstetrician what medicine has been going on before and what to switch it on to. It's similar with diabetes. All anti-diabetic medicines cannot be given during pregnancy. So always consult a diabetologist, and medicines that are safe during pregnancy should only be given. It is very easy to manage these cases if you remember these simple principles of enrolling the patient soon, telling them not to smoke, telling them to take salt restricted diet. Generally, they should be confined to dark rooms. Light triggers this eclampsia. So they should not be in exposed to television or to the phone or to very bright light. Also, they should have a good hemoglobin. For that, they should have a good diet, they should take rest, and they should follow the instructions very carefully. It is very easy to manage them if the patients are obedient, and we don't land up with IUFD or with death of the pregnant woman. Touch wood, I have not seen a single death. We have managed all the patients very well, and it is very important that these patients are managed well, because they can be managed. Also, I have seen in HIV mothers, the incidence of preeclampsia is more. So always recheck their triple H factors when they come to you, because there is definitely a problem in the placenta, and that is why their BP. I've had a patient of HIV who has had 9 pregnancy losses. So I feel we should look into these factors, and we should help the patients by guiding them with good antenatal care.
Thank you so much, ma'am, for sharing this answer on your expertise, ma'am. As I can see, ma'am, there is no more question. I hope you have done justice to this topic, as so we have not received any more such questions, ma'am. And as there is no more question, ma'am, with all your permission, shall we conclude this session for today?
Thank you.
Okay, ma'am. Thank you so much, and take care of yourself, ma'am, and hope to see you again with different topic in future also, ma'am. Thank you, ma'am.
Thank you.